first, since it is a smaller group, we kind of wanted to go around and introduce yourselves, say kind of what role you're in, if you're in educational leadership or a medical student. So I am Joe House. I am the Clerkship Director at the University of Michigan. I'm also one of the Assistant Program Directors there as well. So why don't we go ahead and start with, so this first table over here will be kind of the presenters that you'll see kind of step in and out, and then hopefully add some of their sage advice as well.
Yeah, I'm Kman. I'm the Academic Program Director for the 4th year of medical school in Ohio State. I was the Clerkship Director from 2009 to 2015. I helped with this session last year, so hopefully we learned some things from the participants, and also put in a plug of the past president of SAEM, Clerkship Directors in Emergency Medicine. So we'll refer to that organization a little bit while we're here.
Lawson. I am from Rubrics School of Medicine at East Carolina University. I'm an associate dean for curriculum innovation and medical education.
I'm Nicholson. I'm one of the chief programs at the University of Michigan. I helped with the session in the last.
Peterson of Michigan as well, and doing the education fellowship and working as assistant coach director.
I'm Jason Hagel. I'm a third-year resident at the University of Cincinnati. Malone. I will be the Clerkship Director at Peterson.
I'm Alex. I'm the program director for the University program in Florida at Oakland Hospital, and I will be assisting my AD
Steve Hayward is the Clerkship Director at SAEM.
Danny, my son at PJ plug-in. My name is Sam George. Current site director of Peterson. We're starting our school, so we had to take responsibility for that.
I'm going to be the first course director at Miracle Stream.
I'm Chris Maney. I'm the Clerkship Director and Simulation Director at Health in Columbia, South Carolina. I'm now President of Business.
I'm Andy Wayne, rising 4th year and student asset.
I'm Malone, also rising 4th year and student asset.
where are you all at school?
University of Queensland, Australia.
I'm Brianna. I'm in MS1 at MAEd and also SAEM.
I'm Angelo. I'm class 4th year, also MSA at University of Michigan. I'm Chad. I'm a 4th year at Stony University. Also MSA.
Andrew, I think I'm your assigned mentor.
Yes, sir.
So this suffices as a well, we mentioned Peter, so we had to have a second meeting.
Oh, go ahead.
Oh, I'm Matt Ferrer. I'm Matt Malone. I'm the Ohio State there.
I think we had. You want to go ahead and introduce yourself?
Jason Graber, recently hired as Assistant Program Director at Nicholson Hospital Associated USF.
So kind of the basis of this talk was, obviously there's lots of different boot camps people do. They would do residency prep courses. There's boot camps at, when you are a resident or an intern boot camp. There wasn't anything kind of for clerkship directors. And as you can see from the table of our presenters, clerkship can kind of lead to roles throughout the medical school for a lot of people, assistant deans, leaders of different courses. So I think, thinking of career pathways, it's a good way to kind of get into education, get a lot of experience. Obviously coming to these meetings. We'll also try to make some plugs throughout for CDEM, so Clerkship Directors of Emergency Medicine, and for that group, and then for court as well. And in case you can't tell from us yelling across the room that you're advisor, that sort of thing, it's a pretty informal presentation. So if you guys throw out questions or have questions, if we're talking too fast, that sort of thing, feel free to ask questions, raise your hand, throw things at me, whatever you need. The other thing you guys will find out is everybody does things differently, so we kind of talk about best practices, and a lot of it depends on where you're coming from, what program you're at, and if you can actually institute some of these things. So, so this thing is apparently really delayed. So it kind of is nothing disclosed. Whoa, now I'm going to go really fast. Okay. So some of the things we're going to talk about is your assessments, grading guidelines, rater training. So that'll be this first part. Discuss some remediation strategies. Discuss some advising strategies for kind of at-risk applicant, preparing students for SPI. Do they need a third rotation? And that's one to actually get people to get up, move around a little bit. How do you deal with kind of the non-EM rotator? Because, depending on the school you go to, EM may or may not be a required rotation. So, if you look at the national average, we're about, I think it's about 10 to 12% of students in medical school go into EM. So you're dealing with 88 to 90% of students that are come through rotation that don't end up going into EM. So how do you keep them engaged? So again, how do you utilize some interactive instructional strategies? The ED, as we know, is very different. It's a very different learning experience for our medical students. So how do you create that positive learning environment? How do you address student mistreatment? The ED is becoming more and more busy, no matter where you are. So again, how do you keep education in the forefront? This is a session that we changed or added this year, slow writing. And we all have our kind of own horror stories of reading slows and what are they trying to say here and what's the underlying meaning of this. So we'll talk about that as well. And then LCME. Our LCME is actually coming in next year, so how does the EM department or your clerkship rotation, now the speaker's on, so I echo, how does that tie into, how can you contribute to a successful or maybe unsuccessful accreditation? This is just jumping right ahead. So there's lots of papers out there about comments on variations in grading. Do you do normative? Do you do criterion based? So normative is that bell curve. You have fewer failures every year versus the criterion based, which is more skewed toward honors, being a successful program. So things we would look at are reliability, so kind of try to clarify what each category means. What does an honors mean? And that's one of those things is that we try to, people, again, we'll talk about this when we go to the SLO, we see it that slow and we try to say, what is our distribution of grades? Do we give everybody honors? Is everybody a pass? So the educational theory is we shouldn't expect uniform grading distribution. So it's not going to be that perfect bell curve. You may have, depending on your program, more people skew toward the higher end of grading. And again, there's nationally these variations in your patients, your teaching, your curriculum. So all these things are going to, make the variability of one program compared to the next. You focus on mastery-based goals, and then there's something you actually eliminate the letter grading, because again, if you want to say that people are competent to graduate, competencies are tough to kind of take, those numbers or however you do it, and then say it into a grade. And then if you get rid of competency or get rid of grading, what happens with residency? What happens to the matching? Our surgery program for a while, there's some schools they actually didn't look at because they didn't know what to make of those students because there weren't any grades with it. They graduated or they didn't graduate. This is the most sensitive one ever. Wow. Okay. So there's national effort to, again, differentiate the students. Then the question, there's a letter to the editor. Yeah, this was being really delayed, so maybe I'll try this one. Okay. So based off of this paper, this commentary on the variations of paper, there's a letter to the editor saying, national effort to differentiate students is not worth it. We should actually, again, focus more on those low performers, the bottom 5%, 10%, whatever you identify. We really should focus our educational efforts on those. Then there's a response to that letter to the editor and saying, no, we need to focus on the process. You should be transparent, identify the struggling trainee, and again, add value to our faculty. And again, that's one of those things when we talk about the SLOs and other things is, again, being transparent about the performance of our students. Another response to the letter is also, it's too time consuming. It's not just normative or criterion. We actually, again, need to be consistent. So that way, with the medical student, again, you want those grades to be consistent so you know where you are, where you rank, where you compare, that sort of thing. And the same sort of thing, I think a lot of programs, if you're doing reading letters and SLOs enough, you get an idea of how people write their SLOs, how they do their grading, so you kind of get that consistency. So again, we should be consistent. We do grading our own way, just be consistent in how we do it. this is not working. So what are some of our own data? So this is our own EM data. So faculty evaluations correlate poorly with medical student examination. So performance in a fourth-year emergency medicine clerkship, clinical evaluations compared to written exams. So again, there's potentially poor correlations on how we actually rate our students and how they're actually performing, or how do you compare across. So this is one that I was involved in, and a couple of programs are actually using this. But again, there's a national clinical assessment tool for medical students in emergency medicine, so the NCAT. So looking at developing a national assessment tool. So a tool in theory that you'd be able to use across all institutions. So again, when you're looking at SLOs, you'd be able to compare one-to-one a little bit better. But, so we have 4 institutions here, and I think half are using, half are not. And the 2 that are not using this because our medical school wants to go more to competency-based, and our competencies don't line exactly up with the NCAT tool. So again, even though there's that national effort to try to be a little more consistent, there's always barriers that you run into about being consistent.
So yeah, we at Ohio State, we use, I guess we could call it a modified NCAT. We took one of the questions off the bottom, but one of the things that I'll just throw a plug for is, one of the things CDEM has done is try to make the life of a clerkship director easier. And I think there was a process when all of us started as clerkship directors where we had to invent our own end of shift card and write our own exam. And over the past, 10 to 15 years, CDEM has worked to get those things together for you. So now, if your institution is willing to pay for it, there is a NBME exam that was written by medical student educators in emergency medicine. It's $44, I think, a test. So fortunately at our institution, we do provide it for the students. The NCAT rolled out, 2 years ago? Yeah, so so instead of having to write your own end of shift card, you can use this as long as your institution's all right with it. And it was a end of shift card that was designed by consensus of SAEM and CDEM members of what items should be on there and how students should be graded. And you guys were, part of the task force that did that, so you can talk more about it. But if you don't have an end of shift card and you're not interested in kind of reinventing the wheel, I'll certainly put in a plug for this. The other thing I'll say is, some of us are on Twitter. I tweeted out a link to this. So if you go under the hashtag SAM19, you'll see a link to the paper that has this, and you can download it and look at it.
Kathy Miller is doing a talk on the MCAT this week. If people are interested, we do have a database set up where we're trying to actually do a large-scale validity and reliability study. So she's going to give a report out. At this point, we have actually over 6,000 evaluations. If it's modified, we can't really include that, but for folks who haven't modified, we have pretty large-scale reliability and validity study going. So if you'd like to join that consortium, let me know, and I can give you some more information about that afterwards.
So grading grades, why do we do it? So like Ken mentioned in the one paper, is it to identify the low performers? Is it to identify the high performers? Is it for that residency match? That's your goal, is you got to get everybody matched. Or is it because, what the med school says you got to do it, the LCME says you got to do it. So again, why do we do it? So again, this is going to be a little more specific to EM, and then I'll go into what we do. So this was a paper a couple years ago, kind of what goes in the grading. So the state of the undergraduate education in emergency medicine. So they surveyed clerkship directors. 80.4% used an end of the shift assessment, 57 used a written exam. I think when this was put out there, this was actually before the NBME advanced clinical examination for EM. The medical school and then a mandated direct observation. So we don't have a direct observation, but I do know other programs do. And then professionalism was what we count. So you get 10% just for showing up for shifts on time and showing up for your didactics, but the other one also has conference attendance, things like that. So this is what kind of the national of what people are doing. But again, obviously there's variations because we don't have the direct obs. Medical, and then kind of what goes in the grading again is that medical schools. So our medical school says that we should have 30% of our students get honors, 30% get high pass, and 40% get pass. So again, that's, your med school may or may not have that. Your med school may just be pass-fail when it gets to your EM. So we have some control of how we calculate our grades, and then some of that's out of our control. And then what do other rotations do? So our med schools try to standardize across the different rotations on how do we calculate our grades. So again, when I took it over, we were completely free. We were considered a fourth-year rotation. We got to make our own end of the shift evaluation cards. We got to do our own grading. And then, even though we were required, they kind of said, well, since you're required, you probably should match up with everybody else. So we've had to go through and make all these changes. We went from a 5-point scale to a 9-point scale, and so you have to make adjustments with that as well. So again, you have some freedom over it. Other times you're going to have a lot of direction from the med school. And what we started doing, because we talked about in one of those papers how there's lots of variations in faculty and how we're doing evaluations. So what we started doing is every year I go through and show them what the evaluation card looks like, go through what the different points are, kind of say, this is where we expect. And actually now I have a mixture of M3s and M4s that come through. So I have 18 months where they may be just finished their core rotations, or they may be ready to graduate. So going through and I tell our faculty, don't focus on where the student is, focus on what their performance is. And we kind of make, again, those adjustments on the back end with their grading. So we kind of have two different grading rubrics that we use. One, if it's an early, we have it's tree and branch analogy. So early branch student, meaning they've all completed their required rotation, or is it someone who's late and ready to graduate in a month or two? So we go through that with all of our faculty, go through with our residents, and I have 4 different sites. So I'm actually going to the different sites and kind of saying, hey, this is what the grading rubric should look like. We didn't do it this year because we've had massive turnover in our admin staff, because there is somewhat intensive admin support needed for it. But we actually, for a couple of years, we're providing all of our residents and our faculty, what was their mean score, what was the mean score at that site, what was the overall mean score. So again, people were able to kind of compare how they're rating people to how other sites are rating people, or people even within. So it's interesting. I think, I didn't know I was a Dove, or I didn't know I was a Hawk, or wow, I'm a really easy grader, aren't I? So you start having that conversation, and that's just what some of this is kind of people realizing, where they are in that spectrum. And then the other thing is, and we're still in the process of kind of working on that, is actually, again, telling our faculty and residents what should you actually expect from a student. And again, that may vary on where you're at. I have, like I said, I have the 4 sites, and at one site, I expect all the students to write notes. The other sites, students aren't allowed to write notes. So again, your expectation of those students may vary also from site to site. So again, this is how we do our grading rubric. So 7% is clinical, 20% is your exam, and then 10% is professional. And again, that was kind of based off of what our medical school required of us. And again, that's some of the national data that we showed earlier. The way I do my cutoff, and again, I'd like if you guys, how you guys do it, to kind of chime up a little bit, is I actually look at the performance of last year. So I'll look at all the clinical scores from last year, and I actually will then rate them that 30, 30, 40, and use that as my cutoff. So, and I'll look, there's, okay, this student got a high pass, and they're actually in the top 30. They should have got honors. But I can't go back because, these students are already graduated, these students are already matched. So I don't make that post change like a lot of the other rotations do. Like internal medicine, for us, it's during their second year. So at the end of the year, they'll actually make those changes to grades. I can't do that because I've got students who are graduating. So I actually said, I'll look at last year's and say, okay, this is the breakdown of last year's performance. I actually haven't made any changes over the last 3 years because they've been pretty consistent. Now, again, looking at this year, for whatever reason, I think all our faculty and residents are drinking the happy juice because everybody's numbers are real high, so we're giving a ton more honors and high pass. I have some ideas I can kind of mention toward the end of why that's happening, but so this year we might be more of a 40% honors and 30% high pass, 30% pass, but that's how I set my criterion for exams. I also have a cutoff for honors for the exam, and again, this is trying to be consistent across the medical school, where you have to beat last year's mean. And again, we use the NBME exam. Now, our grades are all done, though, by our grading committee. So we've had students, and Will Peterson's on our grading committee. Adam Nicholson, when he has free time, shows up for our grading committee. There'll be students who, lots of comments about, best student ever, but then they scored just below the mean. We'll bump them up and give them honors. So it's strict criteria, but it's not strict criteria at the same time. Like I said, we do it by our grading committee. Because we've also seen those students who are, got the numbers for honors, but then you look at their evaluations, their comments were like, good student, worked hard, did fine. just not those kind of some of those attributes that we would expect from a kind of honors level. So that's kind of why we set that kind of cutoff in there. I don't know if you guys want to, yeah.
Are the people on the green committee also the residency leadership?
Not all of them. So for us, so I've got dual roles in residency leadership, but then we have 2 other assistant clerkship directors that are pretty much purely just do that. Like one of them's at one of our off-sites, one's at our site. We have 4 residents that have interest in medical education that are on there as well. So it's a mixture. And then obviously with that many people, not everybody can show up, so we do ask people to kind of send us comments. So we'll send out the grading or the grade spreadsheet the day before, the weekend before, and say, hey, give us comments on these students. We end up only having maybe 2 or 3 students out of our 15 to 20 each month that are kind of in that gray zone between the 2 different grades that we spend a little more time discussing, because a lot of them are kind of clear cut. You're the lower end of honors or lower end of high pass can do that. We generally don't downgrade anybody though. So if your numbers in your exam get you to honors, even if your comments are not great, we're going to kind of keep you where you're at. Yeah.
Do you have exterior rotate with your school students? Do you have exterior students from our school to rotate their site?
Yes, we do. So we actually, this will be the first year in probably 2 years we've been able to do that because of the numbers. But what?
I think my next question is, so to give us an exam, is that the immediate
Yeah.
exam? And how do you plan to do that with the experts who, I don't know, you take it immediately at your school?
Yeah. So our school actually pay for all those visiting students to take the NBME exam.
But they might take it at that school.
There's multiple different versions of it though, because I've actually asked students, is it familiar? And even talking with NBME, they know who has taken it before or not. They know which version of the test they've taken it before or not, so that they're not getting those duplicate exams. I think there's 4 different versions now. I think that was when we met this last summer writing more questions, is it actually increased the number of versions of the exam.
I will say, we actually this past year separated them out, so they're really embedded in the same clerkship, but for our registrar, they have 2 different numbers. And we, for our visiting students, administer the SAEM exam, and for our home students, we administer the NBME exam. But we know, having done it enough years, we know sort of where those scores fall, and the cutoff points are a little different for each of them. But if cost is an issue, which it is for many places, and the NBME exam cost goes up, lots of times your institution won't necessarily factor that into paying for it. We haven't passed that fee on to the students, so that's one way in which you could actually get around the exact same.
Is the information that you have about comparing SAEM and NBME scores in each year?
There are national means and all available for each of them, and so we, at our institution, in order to pass any clerkship, you actually have to score at the 12th percentile nationally, and so we use that, and then we, various clerkships have different cutoffs, but we can share that, that the information, there's 2 different versions of the exam, and the national mean is a little different for each of those versions, depending on which you administer it, so that's why we tend to use the percentiles, but we definitely get that passed on to everyone.
Yeah, so at the end we'll have our email address up there, so feel free to reach out to us. Yeah.
I would make a plug. A lot of you, it sounds like, are starting a new clerkship, and that's a tough thing to do. But I try to make the argument that the EM shelf, the NBME shelf, is one of the closest things to studying, right? Because it's kind of all inclusive. So I would really make a plug for trying to build a case. If your institution gives NBME shelves for neurology, psychiatry, peds, why not emergency medicine? And try to get them to finance it. Because I think our breakdown is a little different. It's similar. We're 50% clinical evaluations. And remember, the clinical evaluation is where you're kind of assessing patient care, and the shelf is where you're assessing medical knowledge. That's 35% of our grade. And then we have 5% for quizzes. We have a summative sim, which is like the EPA 10 simulation. Students have to run through 4 cases, and that's part of our grade. And then we have 5% professionalism as well. So, I just think it's important. If you're only doing the end of shift part, then, there's a lot of competencies that you're not really So, I would encourage you to try to sample each of the different competencies and not just the patient care competency.
And just for curiosity, how many people have required PM rotations? And how many are electives? How many people are doing like selectives? And how many have like M3 rotations versus M4 rotations?
We have,
So it's pretty much all there. Just helpful for figuring out where people fall.
And that was actually, so when when I started doing the clerkship, there was not the NBME exam. So that was kind of my argument of why, we should be giving that exam, is exactly what Nick had said. That's what, we're required rotation. You're expecting all, 170 medical students coming through here. Why not give us the same support that the other clerkships are? Okay. Any other questions about the other thing then, and we're actually going to start looking at this a little more scientifically. So the other thing to think about is, if you're doing the end of shift card, is how you're actually getting that out. And I think every year there seems to be people presenting on, how do you get more of that feedback back or better feedback. Kind of anecdotally, and I think Will can talk to this as well since he's been on our grading committee. This year is the first year that our medical school has actually given the students the ability to kind of push out our electronic evaluation. Because obviously there's the paper versus the electronic. And I wonder, my thought is that might be why we're actually getting higher scores from students, because we're actually seeing more evaluations that are being completed kind of real time. We've also seen a big uptick in the quality of feedback to the students. There's actually stuff that's actionable versus the did well, was asked good questions, that sort of thing. We're actually getting very actionable items. So that might be why we're seeing our numbers up. So that's other things to think about is how do you get those end of the shift evaluation cards out. We actually do a paper and electronic form. So it's just a little aside.
Yeah, one thing that really helped us, we used to have paper forms. They were on a green piece of paper, and our clerkship coordinators spent their whole life trying to round up green pieces of paper. It was, sometimes we would come to the grades meeting and there would be 3 green sheets on a student, and they have to do 15 shifts. So it was suboptimal, because then I would have to call the site and say, hey, where's the rest of these? So we went to electronic, and our clinical performance assessment is tied to attendance. So we tell the students, if we don't get a CPA back from you, a clinical performance assessment, that's your attendance mark. And at first we weren't sure how that was going to go with our sites, but it's actually worked really well. So now if we don't get an assessment or an end of shift feedback back from that student, we go to the student and say, hey, why did this happen? And sometimes, the attendance of a trauma or a stroke or something, we understand that. But I would encourage you to tie it to attendance, because that really helped us. It took a little growing pains, but once we got there, it was really good.
Did you have a student sit down with the attending an admission? Because we do both, we give them an option for paper or electronic.
Yes, what we tell the student is to find the attending an hour to a half an hour before the end of the shift. So we don't want them coming up to the attending at 2:59 and the sign-up's getting ready to happen, because we want the attending to sit down with the student and have meaningful feedback. We use an app that's called My Progress, there's different apps that you can use, but our CPA is uploaded in there. And each student has an iPad, so they just hand the attending their iPad, and they go through it. And then they can actually dictate with the comments how the student did. They can hear the feedback that way. And of course, some faculty are better at giving feedback than others, but we've found that works pretty well to just have this be student-directed. Find your attending an hour before the end of the shift, hand them your iPad, or if you're using paper, and then it really helps to tie it to attendance, I think, as well. So.
And since our students now send it out electronically, that we tie to attendance as well. Because we used to do a matchup sheet, because residents and faculty are switching last minute, so they had to write who they worked with. We had people initial it, because you always get that, I didn't work with that person. It's like, well, that's your signature, you did. So that's how we're tying it. So at the end of the rotation, our students need to do a signed 14 evaluation. They do 15 with one nurse tech shift. So the nurse tech shift, because it varies so much, we kind of make that optional to assign one. But every student needs to have 14 evaluations assigned. And if they don't have those 14 assigned, then our assumption is that they didn't show up for their shift. And again, we get on average about 9 evaluations out of the 14 shifts for people.
Do you have a minimum number of shift cards that have to be returned for honors? So you need 100% return.
We expect everyone to return 100%.
In order for honors or for math?
Every student is required to return 100%.
Because that's their attendance marker if they were at the shift.
Otherwise, it's assumed that they will not show up to the shift.
We'll contact them if we don't get one and say, hey, what happened here? As long as, I mean, if they have a good story, we usually let them slide, but we don't have a, you know, the expectation is that you should have one for every shift. The other, just a couple of things, you know, your job is also going to be faculty development. So you had talked about hawks and doves. If you can get to the point where you can figure out who the hawks and doves are and give them feedback on that, that can really help because you're going to see that there's faculty at your place that give all 5s every time. And that's just of no value because you're not going to be able to differentiate your students. So if you have an office of evaluation at your institution or someone that can help you with like a Z-score for each faculty member, that was helpful for us. You know, you may even have sites. We have sites that we have to add a correction factor to because they score students really highly. One of the things that Joe said that Luan will probably touch on is the LCME mandates that you have consistency among your sites. So, I mean, little things like you mentioned where some students come back and some can't, that's true of a lot of places. But if you have some students seeing required pathology that you require at other sites and others that can't, you have to make the sites consistent. So I just wanted to mention that when you had said that, because we have the same thing, differently on ours, but you really should have consistency within the sites if you have a bunch of different sites.
Yeah, so something to report out is grade consistency, like you said, experience consistency. And then usually if you have required experiences, you need to have some sort of almost like a makeup assignment if they don't see that patient. You know, if you're shortness of breath, you know, for whatever reason they didn't see your 5, how are they going to make that up? And we even have, you know, we have an IV session as part of our orientation where they all start IVs. You know, we have to come up, okay, so what happens if the student misses that for whatever reason? And you know, I had a student email me on Sunday saying, hey, my wife just took the labor, I won't be in the orientation. So how's the student going to make up the IV session?
Our students send out like a survey link to whoever talks to your residents, but ours is not connected to this. But we've been doing it like that now that our faculty members know that they only do really things out. And so we were actually able to do a reliability analysis on our data and see if 8 of our members, when we make 8, their reliability goes over 90%. And so we told students, like, it's in your best interest if you want to get these students back, the more the better. Because that's going to give us the best for sure their performance. And so usually we don't have like something getting in, students appreciate like that's what they need to really get a good measure of their performance and our faculty understand that.
Nationally, one of these surveys, that was one of the questions, what's your minimum threshold? And it's like typically 7 to 8 is the minimum number. We do not get 100% of the evaluations back, I'll be honest. And I do think it's a challenge. We went electronic and we had our numbers increased, so we went back to paper forms. And I think we struggle with having people turn things in, but I do think that giving somebody a card, and we also want our students, it's very process oriented about an hour before the shift ends because I was tired of the, oh, by the way, you fill out the same on the way out the door, and it's to check out. So they prompt with discussion, so I do think they actually have very valuable discussion, and the feedback is fit for the rotation, that feedback is helpful for them.
How do you get the faculty or the evaluators to fill out the comment sections, like the summary comments? Because I didn't, in our electronic system, we can manage a lot of boxes, but every time to like write comments and.
So for us, that comment section is required. They can't actually submit it without putting something in that comment section.
Like, it can just not there, and just like.
They can, but that's one thing, again, now that we're getting the electronic ones the students are sending out, we're also seeing, like I said, better feedback and less of the ... or AAA or whatever they're putting in there. So again, in
I think that really has to do with faculty
Yeah.
development, because there's a difference between getting people to write comments, but if they write read more, it's not really helpful comments anyway, might as well left it blank. And so I think a lot of it is understanding doing the faculty development so people understand what they are utilizing the comments for. And sometimes I think we think about it in terms of the remediation piece and how do we identify the learners who are in trouble. But, our high performers want to know what they're doing right as well. And sometimes being able to identify what exactly is going well, even though the students consistently getting honors or great job, it's hard for them to identify what exactly is it that people really appreciate the most. And so ultimately we're preparing them to be better residents if we can provide them with the feedback. And we try to emphasize to the faculty that a lot of these people might stay on for residency and do family medicine or internal medicine or peds, and they're going to be rotating with us again as well. And so investing in them as a medical student is really critical for how they ultimately perform as residents.
And we changed our prompts on our blog, so ours are very specific. It says what's one thing the student do well on the shift that you can keep doing, and then what's one thing the student should work on for next shift. And so that really helps people make sure they know what they're doing on that.
Yeah, we changed ours. So ours is the keep doing, start doing, modify is what we have, the terminology we use for ours.
That's good. So instead of keep reading, we could just type reading.
Exactly. So, again, making it easier for
That's the
them.
problem everywhere. I echo what Luan said. You just have to, at your faculty meeting, just keep displaying the importance of confidence, because keep reading is not helpful. Yeah. And then if you can incentivize your faculty with teaching awards or, somehow incentivize the good educators, that helps as well. But we still get a lot of blank comment boxes. If it happens. So.
Yeah, so we have teaching awards for faculty, teaching awards for residents. And what we do actually do so we don't get 100% back. We on average get about 9 back per student. But what our department has started doing is actually incentivizing faculty to complete evaluations. So we have to have an average number of 3 evaluations completed per month per faculty member in order to it's tied into our bonus system is how we do it. So we have an EVU system, so educational value unit. So that's actually tied into EVUs and then our bonus structure.
Just for my own education, how many of y'all have your 4th years paired with senior residents rather than faculty for some shifts? And do you weight those evals the same or?
Great question.
So
we have dedicated teaching residents, so the students work with a dedicated teaching resident about half of their shifts, a third to a half of their shifts. And at first I was very leery of how are we going to use resident feedback. It turns out that sometimes the residents are actually better at it than the faculty are, and so now we count them equally.
that's what I was going to say. Is I think some of our residents are better instructors than some of our faculty are. We count them equally. Ours are almost 50-50, depending on the site. So at one of our sites up in Flint, so at Hurley, it's probably actually closer to 80% of those are faculty versus 20% that are resident. Henry Ford up in Detroit, we have rotation there. That's probably all, or mostly, if not all, resident. But our other 2 sites are about 50-50.
We have our coordinator take the resident evaluation down, and we look at all of them. When we have our grades meeting, we look at all of them, and usually the resident ones are pretty much in lockstep with the faculty ones. I agree. I think as time has gone on, there's been a lot more resident as teacher instruction, and I think our residents, again, are pretty good at doing this. So we tell our students they should staff 50% or better of their cases with attendings, but it kind of depends on the attending. Sometimes the seniors do a lot of the teaching, and sometimes the attendings.
And follow up to that, do you allow your residents to attend your faculty development sessions geared at improving student evaluations, or are you holding that as?
I usually repeat my session. I'm usually doing one at the resident and one at the faculty.
Separate.
We kind of do the same thing. Our residents, there's like the whole
All right, so I